Now we'll talk about gastric bypass. Tell us about bypass, and then I have a couple of questions.
Absolutely. Absolutely. So gastric bypass is different from the sleeve, chiefly because now not only we're dividing the stomach to make a small stomach, but we are rerouting the intestine as well. So not only the person will be receiving less food in a smaller stomach, but that food will be processed differently now because we have moved the position of the intestine. So the stomach, as you show on that picture on the right, essentially has been divided high up, where a small stomach now is still connected to the food pipe, but completely detached from the rest of the stomach. And then what we've done is we've divided the intestine lower down, and we brought a loop of the intestine and connected it with that little stomach. So food, as depicted by that blue arrow, now will go straight into the intestine. It will bypass the larger stomach and the early intestine. And the acids and juices that are critically important for digestion and absorption will still be produced by the larger stomach in the early intestine. And as you're depicting them by that green arrow, they will be going down that route and catching up with the food lower down, right? So now that early portion of the intestine, which is extremely active in getting the food absorbed very quickly, it will be deprived from any contact with the food. The food will not be contacting that early portion of the intestine, which means that now we are interfering on how the intestine absorbs the food as well. Now, this procedure is the classic procedure. It was a gold standard for many years. When I was first training in bariatric surgery, we just had the gastric bypass mainly. And that's what we offered most patients. And it is a great procedure. There's no question about that. The point that we are bringing right now is that there is actually a downside to rerouting the intestine. And that downside can be avoided by doing the sleeve for most patients, right? Now, clearly, there are some patients on whom the sleeve may not be appropriate, but these are not very many. The vast majority of patients who are trying to achieve significant weight loss can achieve that by and large with the sleeve gastrectomy. But the gastric bypass is also a great procedure and is still avoidable. For instance, for patients who have problems with their food pipe related to severe heartburn, for instance, the gastric bypass may be preferable. And the downside of rerouting the intestine clearly is the fact that now you're interfering with the absorption of necessary nutrients like vitamins or micronutrients as well. And if that can be avoided, of course, it is preferable. Clearly, the decision as to which procedure has to be done ultimately will come down to the wishes of the patients, provided there are no major contraindications to their choice. And in my view, I always say to patients that when they are faced with morbid obesity, the worst choice is to do nothing, right? I think that is clearly very important. Having said that, there are clear advantages to the gastric sleeve or gastric bypass when you compare it to the band, right? The gastric sleeve or the bypass, first of all, are much more powerful in inducing significant weight loss. So when you're looking at somebody that needs to lose close to 100 pounds, they are more likely to achieve that with one of those procedures. We call them stapling procedures as opposed to the gastric band, where we are placing a device around the upper portion of the stomach. From a patient's point of view, there is an appeal to the gastric band, Kemal, and that is we are not rerouting any organs. We're not taking away any part of the organ. We're simply placing a device that can be removed. So conceptually, the patients find this more appealing in terms of really not burning any bridges, so to speak, right? They want to do something that they can get out from, so to speak, right? Well, and based on that, when it first actually was popularized, we did a lot of gastric bands. And I have to tell you, I still have patients that have operated in the early 2000s, and I placed the band, and they still have the band, and they're still very successful. So, but we're talking about, in the vast majority of cases, however, there are problems with the gastric band where patients end up having the band removed, particularly because the quality of life tends to be difficult with unpredictable throwing up or difficulty swallowing, or just going back and forth between the band being too tight or too loose. Remember, the band, is this little ring, and on the inside of the ring, there is an inflatable portion that we're actually able to fill with saline, or we're able to remove saline from. So it's an adjustable band. So we can tailor the tightness of this ring according to the particular needs of the patients at that particular time. But sometimes this doesn't happen precisely, right? So it's a band over time could become too tight just because the reaction of the stomach wall over time leads to thickening of the stomach wall itself, which makes the opening within the stomach itself smaller. So even though they haven't had any adjustment for years, suddenly you will find some patients coming into the office saying, hey, I can't swallow anymore, right? And we tell our office all the time that when we have patients with a gastric band that say they cannot swallow, they have to be seen that same day. It's very important because it's very uncomfortable. We have to be able to see those patients remove the fluid so that they can swallow and get hydrated, essentially. So these are the issues with the gastric band. Clearly, the gastric band is still an option, and for patients who really see no other comfort, for themselves, it should be available, and we should be able to work with them. And as I said, in some patients, it works marvelously. And as I said, we do have patients who had the band for almost, actually 20 years now, and they've done well. They've done well. But it's not certainly my first choice at the moment, because we can achieve a lot more with a relatively safe procedure like the gastric sleeve.
So actually, since I'm not a clinician, but once I understand the technical part of these, immediately what I see is, okay, I know how sleeve works. So there are certain things that's not going to be part of me anymore. So on the stomach. So then I know there's a smaller part where the band seems like it's just slowing down the process, but it's not stopping. It's almost like, you can correct me if I'm wrong with this one, but I'm just saying this from the non-clinician standpoint. So, because you put the band, but the stomach is still doing what it was doing before. In terms of
it does. So there are actually some other mechanisms with which the band works that are not clearly defined. For instance, the actual pressure of the band on the outside of the stomach and some of the nerves that run in that area does impact metabolism to some extent. So I wouldn't call the gastric band necessarily a metabolic procedure, compared to the sleeve or the gastric bypass, but there is some impact. So it's not just about restriction. There are other advantages as well. And that's illustrated in some of the patients who do absolutely fabulously. I have patients, Kemal, who have lost 150 pounds, 180 pounds, and kept it off for over 10 years with the gastric band. So it does work in certain settings. But when you look at its application in the vast majority of cases, we struggle with the quality of life and with the fact that complications occur requiring removal of the band. Clearly, obviously, with placement of the band, like all these surgeries, but also specifically with the band, a follow-up is very, very important, because it's a device that you have inside, and that device has to be monitored with, on a regular basis. And of course, we try to get our patients to understand that as well. But just looking at it from the patient's point of view, though, Kemal, what you're saying, about the intuitive understanding of which is better is logical. But you have to also remember, Kemal, that there are probably 90 patients out of 100 who still do not want to have any type of surgery when it comes to treatment of morbid obesity. So we have still a lot of work to do to get those patients in. And if the only thing that they will accept, is the gastric band, then in the circumstances we have, to educate them and then obviously work with them as well.
No, that's so right, because what I was about to say, that I wrote it down here, what is not an option is not having the surgery, but there are so many different surgery types as an option. So yes. In this case, the band is it's a sufficient, effective way to do it.
If you look at similarity between this procedure is that all those procedures to some extent reduce the size of the stomach that receives the food, right? That's actually a constant for all those procedures. The stomach is made smaller, whether it's by the lap band, where a ring with an inflatable inner surface is placed around the upper portion of the stomach to create a virtual pouch, or the gastric sleeve, when we actually remove more than 80% of stomach, and then the stomach becomes the shape of a slender banana, essentially, or the gastric bypass, where we actually divide the stomach to create a very, very small pouch, or the biliopancreatic diversion, or the duodenal switch, which is in the stomach version is actually similar to the gastric sleeve, although it does have other additions. So there is this commonality to this procedure. All of them create a small stomach. So let's start with the gastric sleeve, right? The most common procedure, very, very popular procedure. And with this procedure, essentially what we do is we cut the stomach so that a larger portion of the stomach, which is known as the greater curvature and fundus of the stomach, are removed completely. So by definition, this is a non-reversible procedure because we are taking out a portion of that organ, essentially. And the person is left with a very slender stomach. The procedure, like all the other procedures, is performed laparoscopically. And this is very important because it allows us to do outpatient surgery. It allows the person to recover from the surgery very quickly. And it allows the person to have much less wound-related problems like wound infection or hernias, essentially. Okay, so with the sleeve gastrectomy, the stomach is a lot smaller. Now, the sleeve gastrectomy is right now in the United States the most commonly performed procedure. And when we first introduced it, Kemal, I was surprised on how quickly it took off, right? People intuitively liked it, accepted it. And if you think about it, people associate their obesity to this constant eating and hunger that they struggle with. And here is a procedure that takes that away completely because it makes that large stomach, distensible stomach that continuously expands to receive more and more food now is restricted. It cannot do that. The person will have a few bites and they feel full. Not only that, but hunger is also under control. That really appeals so much to patients, Kemal, that this procedure has become, in most places, the procedure of choice for most patients. And in our center also, I'm sure you have the figures, that's the procedure that we do much, much more commonly than the others.
So, so we were talking about sleeve, right?
Yeah.
So, although I think
show that after gastric bypass, the food pipe is not in communication with most of the stomach. Therefore, the acid from that stomach will never be able to reach the food pipe again. Whereas with the gastric sleeve, the lower portion of the stomach is still in communication with the food pipe, so reflux could persist. Yeah, as you can see with that diagram, the larger portion of the stomach is totally now disconnected from the food pipe. The acid cannot go back there anymore. So not only gastric bypass is a better procedure for people who have severe reflux when they're looking for bariatric surgery, but also, Kemal, there is the other situation now where we have patients coming for surgical treatment of acid reflux that's been severe, and they also have obesity. In this case, rather than recommending the traditional anti-reflux, anti-acid reflux procedures, we actually recommend gastric bypass. So gastric bypass has become a type of anti-reflux procedure as well. So we're talking about specific situations. And as I said, the key here is that the acid now is secluded away from that lower portion of the food pipe, and therefore refluxing acid into the food pipe cannot happen any longer. And that's the key. Now, let's go to the other issue about diabetes, right? Well, many years ago, one of the pioneers of bariatric surgery published a paper that was titled, "Who Would Have Thought? A Surgical Procedure to Cure Type 2 Diabetes." It was really a very, very interesting paper because he was a bariatric surgeon showing how many of his patients who had gastric bypass and who were diabetic after the surgery were no longer diabetic. Essentially, they've been essentially cured from diabetes. And in some people, actually, this effect is dramatic, Kemal. I mean, I remember, for instance, years ago when we used to do a lot of inpatient procedures at the hospital, we used to have patients coming in the night before for gastric bypass, diabetic patients, and we used to consult the internal medicine, the endocrinology people to manage their insulin. So they would be on different, units of insulin, and yet we do the surgery, and the day after surgery, they would not need any insulin at all. The diabetes just goes away like that before they've started losing an ounce of weight. So there is something drastic that happens when we make that rerouting of the intestine so that the early portion of the intestine is not in connection with the food anymore. Now, this dramatic change does not happen with everybody, but clearly gastric bypass is a very, very good procedure for type 2 diabetes. It is important for us, however, to say here, Kemal, that the effects that we see on diabetes are seen with the gastric sleeve as well. You may have to wait a while for the person to start losing weight, but gastric sleeve is also a very effective procedure for type 2 diabetes.
So, like in that case, like almost like the age becomes the main factor on deciding which procedure would be best, even if someone has diabetes, because we won't do the case until the diabetes is controlled. So then if someone is 37-year-old again, can go back, can do the sleeve, they will definitely benefit from the weight loss. But then let's say if it doesn't work, then there's still time to go to the next level. Like bypass in this case would be the next level. But if you do the bypass too early on, there's no going back. So and then when you put all the benefits and
risks and benefits,
it just makes it pretty straightforward, in my opinion. So that if I see someone in a certain age group with certain conditions, of course, at the end of the day, this decision needs to be made with the surgeon and the patient. But just for patients to better understand why we would actually ask them to do one procedure over the other one, is just because it's better for them with the for their health, and also if there's a less riskier option, why not? Right. So
absolutely. So yeah, that's a great point. Earlier in life, patients in their early 20s, you would be much more reluctant to offer the gastric bypass nowadays when you have the sleeve available, because that person will be exposed for so many more years to the potential downside of malnutrition, vitamin deficiency, with potential hair loss, weakening of bones, poor healing of wounds, as well as potential nerve damage if they're not careful with their vitamin intake. So, and also that the point that you made about the finality of the procedure is very important, right? I explain to patients very often by saying that the gastric sleeve is almost like a middle of the road procedure, right? Whereas the gastric bypass is like the final stop, right? There is not very much you can do or go from the gastric bypass, whereas the sleeve is actually amenable to be changed into gastric bypass if necessary, right? So you haven't played all your cards, with the gastric sleeve compared to the gastric bypass, and that's an important.
You're able to achieve that with less risk, less complication, and less changes in day-to-day what we are doing. So that's really important. So it's not just the risk and the complication, but every day I have to do certain things differently, because it's not the same as the sleeve versus bypass. The bypass is, as we explained, the stomach part is bypassed. That's why it's called. So that's actually, they did a good selection on the term. So it's being bypassed. So now we used to do a lot of gastric band, and every once in a while I see patients are insisting on this. And what I see in the last 5-6 years is a lot of band removals. Because they are actually going to the next level.
You're absolutely right. Risks and complications are things that can happen, during a particular intervention or treatment, right? But the treatment is essentially a choice, a decision, right? And not taking the treatment is also a decision and a choice, right? And then we have to look where each of those roads lead the person, right? Where does a person end up after they have surgery and lose weight, right? What are the risks within that road? And where does a person end up if they don't have surgery and continue in the course of morbid obesity? Where does that road lead them? What are the dangers that are facing them, right? Well, let's look at the most striking danger, which is death, right? That's what we fear about surgery, treatment, right? Is there a risk of dying, right? Well, with any option that we make, with any treatment, obviously that possibility is there. It's never zero, Kemal, right? But if you look at bariatric surgery, the way it has been refined, the way it has been prepared in modern programs like ours, modern programs that have been certified as centers of excellence with very experienced surgeons, the risk of death is way lower than 1%, right? Lower than 0.1%, right? Now, compare that with the risk of shortening one's life if a person was continue to stay morbidly obese, right? We know that with morbid obesity, all the data show it, Kemal, clearly, a person's life is cut short. A person is less likely to achieve their life expectancy, right? If they stay morbidly obese. The higher the body mass index, the shorter the lifespan. So there is no question there. This is not about a 1% issue. It's a 100% issue, right? If you stay morbidly obese, you are not going to be living the way you are expected to be living compared to the life expectancy in our society right now, right? That is that. So when you have these stark figures, you know that the choice should be really clear, which is losing weight with surgery is far more beneficial, much less risky than staying morbidly obese, right? Having said that, it is obviously very important that we educate our patients about the possible risks of surgery. We have that obligation as healthcare givers that every time that we provide a treatment, every time that we recommend a treatment, we have to be able to inform, educate our patients the benefits and the risks. And that is obviously the session today. We will be talking about that. Now, as you correctly said, risks and complications are very different from consequences, right? So a risk, for instance, could be bleeding or blood clots, as we will speak, right? But a consequence might be excess skin, for instance, right? Losing weight, that's a known consequence of the surgery, right? If you're losing 100 pounds, you will have excess skin. That is not a complication of the surgery. That's a consequence of the surgery because of what it does, you lose weight, right? A complication is something very different. We're very happy, obviously, to report that in the way we perform bariatric surgery right now, the risks are very low, particularly the serious life-threatening risks are extremely low. And that is because we focus on prevention so well. And we've been very, very successful in preventing these serious complications in the vast majority of patients. Nevertheless, of course, today's session, we will be discussing. So the first one is infection, okay? Infection, what type of infection? Internal infection. We're not talking about superficial wound infection. We're talking about internal infection. Again, this is extremely rare nowadays, right? And it happens, or it can happen if there is something called a leak, Kemal. And we've talked about a leak and patients talk about a leak, but it's important to make sure people understand what this means, essentially. Essentially, when you do gastrointestinal surgery, the way we do it for bariatric surgery, you are cutting the stomach or the intestine, you are stapling the stomach or the intestine, and you are connecting together the stomach and the intestine to some variability, right? When you make this cutting and these connections, the wounds have to seal with complete integrity. In other words, we cannot have even a bubble of air go through that wound. With that complete sealing of the wound and integrity, there is no problem. But what if there is a leak? What if there is loss of integrity of that healing? Substances that are supposed to stay inside will start leaking out. And a good way to understand it, to have an analogy, Kemal, is to think about the pipe system in a house, for instance, right? We have pipe systems running around inside the walls of the house. Something enters at one end and it's supposed to get out at one specific end. you don't want the pipe to have any defects in the middle, because if it does, then stuff will leak out, right? It's the same thing with our digestive tract. It's one long pipe that starts from one end and finishes at another, right? Stuff goes into one end and then gets out from the end.
Mm-hmm.
It's sealed that way. There is nothing that should be leaking. If it does leak, then you will have gastric juices, acids, bacteria leaking out and creating an infection, right? This is what a leak is essentially, right? And it is extremely rare nowadays with the way we do surgery, Kemal. It's less than 0.1% in our practice, right?
I was going to say that. So I don't, since 2001, I don't actually, 2021, I don't see any.
None, you're absolutely right. That's a very, very few in between. Now, there is different extents of this, obviously leading to different outcomes. Of course, it is a serious condition. There is no question about that. But early identification and early treatment leads to a good outcome, right? And one of the things we do is we educate our patients on telling us if they're not feeling well or doing well, because there are signs of a leakage, right? What are the signs of a leakage? Well, the patient, first of all, are not going to feel well in general. They're going to feel sick. They may have nausea and vomiting. They may have a fever, right? They may have chills. They may have abdominal pain. When any of those things happen, they need to let us know, because this could be the indication is that the leak is happening. And what do we do? Well, we bring them in, okay? We provide them antibiotics and we do tests to see if there is a leak. And if there is a leak, sometimes the treatment might be just avoiding food, right, for a while and giving nutrients through an IV and antibiotics, and that will actually seal by itself. Sometimes we have to intervene by placing a drain or doing surgery. But even though it is a serious condition, it is fixable as well. That's the other thing that is very important to understand. We have to educate our patients about possible signs of this so they can alert us in time. The worst thing that can happen is for this to drag on without anybody intervening, right? So leak, something that can happen with any of these major procedures. It's extremely rare, but it can be serious. It's preventable with the way we do surgery, but also it is eminently treatable.
Exactly. So now when we are talking about the risk, these are the short-term complications, like 0 to 30 days of post-op. So we covered the leak.
And then there are a couple also. I want to add to
dehydration is something that we see maybe a little bit more, right?
What's that again?
Dehydration.
Yeah, dehydration. So right now I am talking about the more serious complications, and I want to add a couple more before we go to the less serious ones. So we've talked about leaks, infections. Again, they're very rare. They can be serious. They can be treated very well, and patients need to be educated about signs and symptoms of that, okay? Another potentially serious risk, Kemal, is blood clots, formation of blood clots. Now, this can happen with any type of surgery. And what it is exactly is that when blood flows inside our veins, the blood that starts from the away from the hearts and then going towards the heart, the venous blood, right? It has to flow continuously. If, for instance, if flow is interrupted, then it can coagulate, it can form clots, right? And these clots can form generally in the legs, for instance. And what is the danger of this, Kemal? The danger is that when these clots form, they can travel all the way from the legs into the lungs, and they can block perfusion or blood flow to the lungs. That is a life-threatening condition, because then you're not able to exchange oxygen. When the blood clot travels to the lungs, it's known as pulmonary embolism. Okay? Now, blood clots can happen for a variety of reasons, right? One of the reasons blood clots can happen, Kemal, is surgery itself. Having general anesthesia and having any type of surgery can increase the risk of blood clots, right? There are other factors as well. One of the factors is obesity. So our patients, by default, are actually at higher risk for blood clots than other patients, because obesity itself is a risk factor. Another risk factor is
taking care. It's like the blood clot is not a risk of. It's not initiated from the surgery. It's the condition that patient has.
Absolutely. The risks of blood clot is there with any surgery, but when you, for instance, start off by being obese, older than a certain age, having a history of blood clots in the past, all that are risk factors that would increase the chances of blood clots. So because bariatric surgery deals with patients that are morbidly obese, inherently bariatric surgery does have a higher risk for blood clots. But this also has created an opportunity for us bariatric surgeons to seek ways to prevent blood clots. And we have them. We have excellent ways for doing that. The best way to prevent a blood clot, for instance, Kemal, is to get the patient to get up and walk early after surgery. And guess what? In our program, patients start walking within an hour or two after surgery, right? Because of the way the surgery is done, the patients have less discomfort and they are able to get up in that. The other two methods that we use to prevent blood clots are give the patient blood thinning medication before the surgery, and in some cases after the surgery for up to 30 days after the surgery, right? To thin the blood so that the chances the blood clots are less. And then a third way in which we minimize the risk of blood clots is to put special boots around the legs of the patients. So when they are immobile under general anesthesia, these special boots will pump the blood in the calves of the patients to get the blood to circulate better. With these methods, we've been able to decrease the risk of blood clots in bariatric surgery to levels that are lower of those thin patients undergoing other types of surgery, right? So this is why bariatric surgery has achieved such a high level of quality now, because it really works in centers like ourselves to prevent those potential complications. Now,
so it always comes down to the prevention. So because
absolutely.
One of the things that we do from the care coordination and daily case conferences, this is one of the items, one of the many items that we are looking for. And it's not just one person or one physician is looking for it, like starting from the surgeon to the nurses to the surgery center. So because we don't want that complication, potential complication, to be missed, because it's really not like, I mean, what you said is true. Patient needs to be walked and other things, but if the patient is not the right patient for that setting, meaning that, I'm going to rephrase that, if the patient was not prepped properly for the surgery, so because our screening process is 2 to 3 months at a minimum, where we are actually looking at what medications they take. They get the cardiology clearance. We look at their hemoglobin and other. Like a lot of times, patients don't know that they have diabetes, or they are not in treatment for diabetes, and then we actually diagnose them because of all the screening process that we go through. So I think risk is there, but how we actually handle that risk, how we are preparing our patients for risk, that's the most important.
Absolutely. So we know what the risk factors are that will increase the risk for blood clots, right? And we act appropriately. So for instance, I do remember, was it yesterday or the day before in our case conference, one of the nurses said, Dr. Erkan, this patient has factor V Leiden, right? This is a genetic abnormality that increases the risk of blood clots. And that's important information for us, because guess what? That patient will not only have blood thinning medications, on the day of surgery, but we will ask them to take that blood thinning medications for 30 days after the surgery on a daily basis. And that will help them decrease the risk of blood clots tremendously. Or if the patient has had a previous history of blood clots, or if the patient has a family history, or if a patient has a body mass index greater than 50, we also know that that can potentially increase the risk of blood clots to a higher level. So we would prescribe the special medication for a patient to go home with for up to 30 days. So blood clots essentially is a serious problem that can happen with any surgery. It can happen even more with bariatric surgery because of the risk of obesity and blood clots, but it's eminently preventable. Now, it doesn't mean this prevention leads it to zero. Of course, there is no such thing in medicine, but it can bring it down to very, very, very low levels, so that this is not something that...
So this is also maybe a good time to reemphasize why we want our patients to lose a certain amount of weight.
Absolutely.
And how we saw some discussion the other day in the support group. Some patients are doing longer diet than the others for the prep because it's all about the prep. So if the patient's BMI is not extremely high for morbid obesity, but not extremely high, then they may be okay with 2 weeks special diet. But if they are way higher than our normal limits, we may ask them to do 3 weeks raw bar diet, because the whole thing is about reducing the potential risk. Because if you don't do any of those, everything is a risk.
Absolutely. Come on, we're talking about complications today. I can tell you, for every complication that we'll talk about, the higher the body mass index, the higher the potential for complications. So reducing particularly very high levels of obesity and BMI, reducing them to as low as possible before surgery actually greatly enhances the safety of that surgery. So there is no question that when sometimes we ask our patients to do 2 weeks or even 3 weeks, and very, very occasionally even 4 weeks of preoperative diet preparation, it is actually a lot for the patients to go through, but it increases the safety of that procedure immensely, essentially. So there is a very important rationale for wanting to do that. Mm-hmm. So we talked about leaks, right? We talked about blood clots. The third one that could be potentially serious, Kemal, is bleeding, right? Well, bleeding has been associated with surgery from the inception of surgery, right? Because with surgery, what we're doing is we are cutting into tissues, and when we cut into tissues, bleeding occurs, right? So bleeding can certainly happen, and we're talking about internal bleeding. Now, this can happen during surgery because there may be a damage to a particular organ and bleeding can occur, right? Or it can happen right after surgery as well, right? The more common type of bleeding is the one that can happen right after surgery. Mm-hmm. And because of what I just said about the blood clot, because we put patients on blood thinning medication, there is actually an increased risk for bleeding as well. But again, it is a calculated risk, meaning that we are able to mitigate that with preventative measures as well. For instance, the timing at which we give the blood thinning medication before surgery is done at such so that when there is a higher risk for bleeding at that particular time, the patient is still in the operating room and the surgeon is looking at the organs to see that bleeding is not increased.
That's already too late.
Right, absolutely. So when we are putting together tissues that we have cut, very often we use special material to buttress those tissues to prevent bleeding. So again, prevention is the way to go, right? But the more important thing about bleeding, Kemal, is that if bleeding were to occur, a serious type of bleeding, it occurs usually within the first 1 or 2 hours after surgery when the patient is being monitored very intensely, right? We have our patients under very intense monitoring in the first couple of hours, 3 hours, 4 hours after surgery. That is a time when we want to pick it up if it happens again.
And that's why the expertise is extremely important, not just from the surgeon standpoint, but for our nurses. Most of the time, all they do is bariatric. So I don't believe there's any other nurse who would know bariatric better than our nurses if they've been with us for more than a year, because the chance of them dealing with the bariatric patients on a daily basis is 80%. So therefore, their expertise is going to be a lot better than anyone else. So this is, from the prep to the surgeon to the after surgery, it's all about the expertise.
Absolutely. So early recognition of the problem and early intervention, again, is very critical here, right? So sometimes blood transfusion may be necessary, sometimes reoperation may be necessary to fix the issue. But again, it is a problem that is extremely rare as well. So 3 potentially serious complications that can happen around the time of surgery, Kemal, but that can be prevented to a very, very low level, but even if they happen, they can be taken care of and fixed as well, right? So serious in their potential, but eminently preventable as well as treatable. Again, the statistics we're bringing here are extremely low, but nevertheless good. And most importantly, obviously, we have a requirement for patients to stop smoking if they were smokers before surgery, but obviously we really recommend and educate them about not picking up smoking again after surgery. One of the consequences of resuming smoking, among all the other consequences of smoking, Kemal, is that if a patient has had gastric bypass, they are likely to develop ulcers. And ulcers can bleed, they can lead to scarring, and they can perforate, right? I had a patient that had been operated about 8 years ago, Kemal, that came in very sick the other day to the hospital because of an ulcer, right? And of course, there is a history of smoking. There is a history of heavy drinking as well, which did not help the situation. But ulcers can be very, very serious problems. Now, this does not tend to happen with the sleeve, but it can happen with gastric bypass. Another thing that can happen with gastric bypass, even in the long term, Kemal, is that because we are rerouting the intestine and taking it away from its natural position, the intestine can twist or enter in some pockets known as internal hernia, and that can cause bowel blockage that requires emergency surgery. So internal herniation, bowel blockage, more likely to happen with gastric bypass, right? And this can happen up to 10 to 15% of times, requiring surgery after gastric bypass. So this would be more particular to gastric bypass. Now, if we
during the process, we are educating our patients with all these, so that like smoking is one of the no-nos.
Absolutely.
They should even entertain that.
Yeah.
Because that can actually complicate, even if like other procedures or other things, it's already complicating. So at this point, this life change journey needs to be fully implemented. Otherwise, the benefit is not going to be there fully.
Absolutely. And what would be more particular to the gastric sleeve? Probably the heartburn or reflux would be more peculiar to gastric sleeve after the surgery. So now patients who didn't have heartburn can develop heartburn afterwards. Patients who had some heartburn can worsen their heartburn, but similarly, patients who did have heartburn, their heartburn may go away after gastric sleeve. So just because a patient does have a history of heartburn, it doesn't mean they should avoid the sleeve gastrectomy, but they should know that there is a potential for the heartburn to worsen and require medications afterward. Now, why is that? What is the cause of that? Well, it has to do with the fact that after the sleeve gastrectomy, Kemal, the stomach not only is small and banana-shaped, but also it's stiffer, which means that the pressure inside it increases, which means that acids from the stomach are potentially able to be pushed back up into a low pressure area, which is the food pipe. And that's what heartburn is acid coming into the food pipe. And that may require medication. As I said, this is not universal. In fact, there are patients who did have heartburn before the gastric sleeve, and then after the gastric sleeve, the heartburn may go away. Perhaps they had something called a hiatal hernia that we are able to fix at the time of surgery, and that leads to resolution of the heartburn. Now, are there situations in which the heartburn can become so difficult to treat that patients require a different surgery to fix that? Yes. In a small minority of cases, some patients who've had a gastric sleeve can develop heartburn. They may require changing their sleeve into gastric bypass to rescue the situation. But the number of patients who require this is so small that just having a history of heartburn should not be an automatic reason for requesting the gastric bypass, because the gastric bypass also has potential risks that I just mentioned, including the ulcer and the twisting. Now we move on to the duodenal switch, and there are complications related to the duodenal switch. As people may know, the duodenal switch is almost like an extreme type of gastric bypass, where a much longer portion of the intestine is bypassed. And as a consequence, patients can develop diarrhea that may be difficult to treat, or they may develop very severe malnutrition, very severe, extreme malnutrition. And if that is the case, they may require reoperation to shorten the bypassed segment of the intestine. So
for the duodenal switch, kind of like the revision, like, because we are doing the second stage of that, we are not doing
absolutely. So duodenal switch can be done either as a second stage procedure after a person has had a sleeve gastrectomy, or it can be the first procedure where the patient will have some type of sleeve and the duodenal switch as the original procedure, essentially. So in summary, essentially, when we look at the major complications that could happen to any of those procedures, we've talked about leaks, we've talked about blood clots and bleeding, and these are potentially serious complications. The good news is that they are very, very rare. If they happen, they are treatable, right? We can take care of them, we can fix them. Obviously, patients need to be educated about potential signs and symptoms of this. Then, of course, we talked about complications that could be particular to each one of those procedures. Now,
done after the surgery.
Absolutely. This is obviously a very important topic, Kemal. Most of our patients will come to bariatric surgery after they have spent a lifetime struggling with their weight, a lifetime in which they have, lost and gained the same amount and more weight time and time again. Every time, they lose the weight, then the disappointment occurs when it takes very little time for that weight to come back. With this type of clearly, almost traumatic experience with weight, it's not surprising that, one of the biggest fear of most patients after bariatric surgery is weight regain. Will it happen again? The good news is bariatric surgery is extremely efficient. Bariatric surgery is extremely resistant to weight regain. Having said that, it's not foolproof. Again, because the problem with obesity is a biologic problem. There is an entrenched drive for our body to gain weight. We are wired to gain weight. And this has to do with our evolution because as humans, the greatest part of our existence, we have spent it really struggling to find food. So we have developed a body that has become extremely efficient in using whatever food it can for energy and preserving it. When you ask a modern person, how do they preserve food, their immediate answer is the fridge, right? We have the fridge. I can keep food for a very long period of time. Mm-hmm. But the truth is that the fridge and other technological advances happened just yesterday. When you think about the human history has really occurred over millennia where there was no way for people to keep food fresh, right? So they had to find food, eat as much as they can when they have it, and have a body that was good at preserving that. Mm-hmm. So the body that we have evolved is extremely good at gaining weight, but it's very, very poor at losing weight, right? So, and that's why, you see people really work very, very hard for months on end to, lose 20, 25 pounds. And it takes barely a week or 10 days of loss of focus for the weight to come back, right? Because that's what our body is. So given that our biology is such, it's not surprising that even after bariatric surgery, weight regain can happen, and it does happen. As you said, typically this starts about a year to 18 months after bariatric surgery. The first year to 18 months, there's almost mindless type of weight loss. Of course, there is the focus as well. Patients and, people who had bariatric surgery are very excited and they are focused as well. But really, the biology that bariatric surgery interferes with is really effective in that early time as well. After that, things can happen that really can derail that. As I said, people may lose that initial enthusiasm, right? That honeymoon period, may recede and they may go back to routines. But on top of that, the body's biology starts to become entrenched. So at that time, there is a danger for weight gain. One thing that is very important to mention, Kemal, is that we have to define what weight gain after bariatric surgery is. And I have to tell you, for people to regain all their weight is actually unusual. It's not common at all. There can be significant weight gain, but for people to gain all their weight after bariatric surgery is not common. What is more common is for people to regain some degree of their weight. Now, they can regain so much that, maybe half of what they've lost can come back, right? Sometimes even more. So from a layman's perspective, when they see people who had bariatric surgery and they see them reaching their goal weight, let's say at 18 months, right? A person who was 250 pounds, now a year later, they are 150. They're the thinnest they've ever been, right? When other people look at them. But if that person were to regain, let's say 30 pounds over the next few years, from the layman's perspective, you know, they're just comparing them to when they were so thin. So from their perspective, it's as if they have failed bariatric surgery. But that's not true. They're not 250 anymore. They may be 170 and 180, which is way better than being 250. So that's the weight regain that we see with bariatric surgery. It's very important to understand that. And of course, we can go into detail as to why that happens and how can patients actually prevent or minimize that weight regain after bariatric surgery.
So I know eating slower or slowly helps, right? So is that something related to like the mindful eating, like when we are eating? So is that the same purpose, or is there a different reason for eating slowly in the process to keep the weight off?
Well, that's actually a great point. Mindful eating is really a wonderful, wonderful tool, Kemal. The problem is, you know, in our society, we are so distracted that it is very difficult to maintain that discipline day in and day out, right? If a person was mindful enough to know that they've had enough food, in other words, they are eating with really paying close attention to what their body is telling them, then they would be able to be in control all the time. But eating is not a practice that we do in by itself, right? It is really mixed with many other multitasking activities that we have in our day, typically socializing, whether interacting with the media, watching something. That's how we eat. And in that process, it's very easy to get lost and not really listen to our body. So our body, particularly after bariatric surgery, does tell us that we're full. In fact, you know, Kemal, there is this myth that people have that, you know, people gain weight after bariatric surgery because their stomach has enlarged. That's actually not true. You know, it's very occasional that the stomach is so large now after surgery that weight regain happens because of that. It's very rare for people to have weight regain because they have problems with their surgery, right? Their stomach, for instance, after gastric sleeve, that was really very tight and small, remains tight and small for years, right? In fact, when you talk to patients who are struggling with weight gain and you ask them about their eating habits, they will tell you they still cannot eat anywhere near what they used to eat before their surgery, right? But what happens is they fail to listen to those signals, right? So for instance, at the beginning, let's say, you know, early after surgery, somebody who's had sleeve gastrectomy, they are sitting to eat, right? It's early after surgery, they really are focused, they're in that honeymoon period, so they listen to their body. So they may feel full, for instance, after taking, let's say, 10 bites of a particular food, right? And if they were to add the 11th bite, they may actually feel discomfort, right? Now, for somebody who hasn't had surgery, Kemal, the difference between, you know, fullness and discomfort is a full course, right? I mean, you and I who haven't gotten an altered stomach when we go to eat, before we feel uncomfortable, we really have to eat a full second or third course, right? But with bariatric surgery, it just takes one extra bite before you feel uncomfortable, right? So the difference between feeling full and uncomfortable is very, very close. It takes 1 or 2 bites to do that, right? So at the beginning, they may pay attention to that. But if they are distracted and they don't pay attention, now it may be, after a while, that bite number 11 may feel comfortable, may be okay, right? And then they may do that with bite number 12. They may do that with bite number 3. So before they know it, now they're consuming 100, 150 calories in excess with each meal. And those calories add up, right? Our body, which is so well adapted at conserving energy, at gaining weight, will suck in all those extra calories day in and day out. And before they know it, you know, within 6 months, they've regained 10 pounds. Within a year, they've regained 20 pounds. And that is a very hard situation because now coming down from that is actually a lot harder than when they start. So this issue about mindful eating and really, really focus on when you feel full is just as important as after bariatric surgery as it is before when you're struggling with weight, with being overweight. Key is that you have technology now that allows you to track that, right? I mean, of course, technology is hurting us when it comes to obesity, because everything is, automated, and we have remote control for everything and we don't move. But on the other hand, technology can also help us because it provides us these tools that help us, right? So I talk about, to our patients about using a smartwatch, a smartphone to track their movement, right? The key word here, Kemal, is movement. When we talk about exercise, sometimes people think that exercise is only when you go to the gym and sweat it out for half hour or 1 hour, 5 times a week and so forth. Well, if you can do that, excellent, right? But let's start with the foundation. And that's what I talk to people. And I tell them, look, what is movement like for you during your waking hours? From the minute you get up from your sleep until you go back to sleep, what is movement like? You actually have technology now that allows you to track that. And the basis of movement for human beings is walking, right? Which means walking to do your own chores, walking to do things, and walking with the, intentionally for the purpose of moving, right? But if we can track that, and if we can see how much we're doing every day, and we are really diligent about that, then we can actually tweak our day to add more steps to our activity, right? So for instance, you mentioned 10,000. 10,000 is a fantastic goal. I think in the long term, we should strive to achieve that. That's what I talk to my patients about, right? Yes, I'm happy if they're going to the gym 3-4 times a week and they're committed in the long term to doing that. But I'm actually much happier if the largest proportion of our patients actually do 10,000 steps a day on the vast majority of days. So if they are tracking their movements, then they will be able to adjust their day to add steps, right? We talk about parking further away rather than closer, right? People fight for parking spots that are closer to the venue very often. And what we're saying is do the other way, flip it, look for the furthest parking spot as safely as you can to do that. Or if you're going to stores, nowadays we were talking about Wegmans the other day with you, look how huge that place is, Kemal, right? So if you need to go to a particular aisle in a store like that, the instinct is to go with a shortcut, right? To go as far as you can. Well, sometimes if you have no time, you may want to do that. But if you have time and you want to add more steps to your day, then you take the longest route. Now, when you are adding steps to your day, Kemal, not only you're getting closer to that 10,000 milestone that you're looking for, but every time you are walking is time you're not sitting, right? So the trade-off there is important because, during your waking hours, when you're not asleep, you're either standing still, right? Or you're moving, right? So if you're moving, you're not standing still. So every time you add more steps to yourself, not only you are adding more walking time to your day, but also you're taking less sedentary time, right? And that trade-off is very important. So I agree with you. I think in the long term, particularly living in a society where everything's so automated, we really need to track our movement. We need to see how many steps we're doing. The vast majority of us work in sedentary jobs in front of desks, in front of computers, right? A lot of people work in that kind of situation nowadays. Unless we really have this mindfulness again about our movements, tracking our steps, then we would be relegated into a situation where we're eating more and less active, and that is a disaster because eventually the weight will come back in some form or another.
So I think what's important for everyone to remember is the bariatric surgery is a tool. Yes. It's not a magic. It's not magic. So it's a tool. So that means everything else that we are going through in our regular life, what Dr. Erkan is going through, what I'm going through, what anyone else, even with or without bariatric surgery, we are still struggling with those. That means once we utilize that tool, then we have to adopt certain things to make sure that we are not going back to where we started. So One of the things
To add to that, Kemal, then, it is, as you said, it's a tool. And also people need to understand that obesity is a chronic condition that has entrenched roots within our biology, right? And the surgery doesn't necessarily fix that biology, right? It helps us. It's a powerful tool, right? But that tendency for our body to want to be at a higher weight will still be with us, right? We have to understand that. Now, so yes, people can struggle with weight gain. They should not be embarrassed because they weight gain. They should be comfortable that they have realized that they're struggling and they need to seek help. Yes, as bariatric surgeons, and as a program, we love it when our patients come and show us how much weight they've lost. We both celebrate, we're happy, but also we're much more useful to them when they're struggling, right? So don't be embarrassed if you have regained weight. Call us sooner than later, because early intervention, early help and assistance actually can be very helpful, right? You want to come and seek help if you've gained 15 pounds as opposed to 50 pounds. It's a lot easier to recuperate from that 15 pounds than it is from that 50 pounds. So that's important. Scheduling regular visits, right?
Well, what I was going to say that from that point, so our program, just like any other certified program, there are certain checkpoints in the 5 years after the surgery, but we are not limited with those only. That's just with your surgeon, surgical office. But if you are you think you are going to have a challenge, our dietitians, nutritionists are available after the surgery, and same as for our bariatrician who's focusing on non-surgical side of it. So she's available. So as you were saying, instead of waiting until it's too late, like come to us when you feel like the trouble started, so then we can actually have an early intervention and not to let this problem go out of control, because things are going to be always more difficult.
Yeah, and also, know that there is a whole community there that can support us, right? We have support groups, for instance, right, Kemal, that particularly now with the, ability to do virtual meetings, right? That should be relatively easy for most people. So our support group, for instance, is the first Tuesday of every month, and it's available to all patients associated with our practice, where they can sign up for it, right?